entertainer as he is up front, but at least I'm going to try my best. I'm very honored and pleased to have Dr. Ron Epstein give this first talk this morning. And for those that haven't met him yet, Dr. Epstein is professor of family medicine and psychiatry, oncology, and nursing at University of Rochester Medical Center. And he directs the Center for Communication and Disparity Research and is also the dean teaching fellow and the Dean Teaching Fellow program. And his research is mainly on improving patients-physician communication and focuses on marginalized populations, stigmatized conditions such as depression and HIV, and end-of-life care. Dr. Epstein is a graduate of Harvard Medical Schools and has authored over 180 publications, and we're very honored to have you here today this morning to give this first keynote talk of the day. So if you want to come up.
Oh, thank you for dimming the lights, but now can anyone see me? I'm very pleased and honored to be here. It's for several reasons. One is that I see the work that the Shared Decision-Making Group is doing is very closely allied to the work that groups that are concerned about communication in medicine. I think this is really an opportunity to build bridges and to consider situations in which both sets of issues are really particularly salient. I also want to thank the organizing committee and particularly Victor for being such a gracious host and inviting me here to be with you. I just want to remind us a little bit about context. We are part of what was one of the largest empires in the Americas, although it's hard to tell that looking at the surroundings in Miraflores. And I think part of the message that I'd like to convey here is that in the world of decision-making and communication, context is everything. And here's a quote from William James that was actually brought to my attention by Ian McWhinney, who Glenn Elwin mentioned in his talk yesterday. And I think this really sums up a lot of what I'm going to be trying to address today. That sometimes an acquaintance with particulars makes us wiser than the possession of abstract formulas, no matter how deep. And so the particulars I'm going to be talking about today have to do with complex situations. And just to give you a sense of what I'm talking about, simple situations are ones where you can have a relatively untrained person follow a recipe and come out with a reasonably satisfactory result. Now, clinically, I'm a family physician, and I also do palliative care inpatient work. So in family medicine, I don't think you need 4 years of medical school and 3 years of residency in order to treat a urinary tract infection. My college-age daughter could learn how to do this very easily, and in fact, probably an elementary school kid could learn to do this as well. So it's really the recipe that's important. Complicated situations, I think, are the ones that we deal with a lot in evidence-based medicine and in decision research, where there are often dichotomous choices and one can apply formulas, and those formulas can include values and preferences in order to come out with an outcome that is somewhat predictable. And often these situations involve dyadic discussions between physicians and patients. But today I'd like to talk a bit about these more complex situations, and the analogy here is raising a child. I mean, how many of you are parents? Okay. How many of you have more than one child? Okay. Now, if you applied exactly the same formula and behaviors to your second child that you did to your first, what's the likelihood that your second child would turn out even remotely similar to your first child? Not very great. So this is really kind of the essence of a complex situation. And so in these situations, and here are a few examples: chronic back pain, third-line chemotherapy, diabetes in the elderly. There are many more. really require good communication, what Aristotle called phronesis, or practical wisdom, and self-awareness. And while recipes and formulas are useful, they're not sufficient. The outcome can never be fully predicted, and often these decisions are shared within a larger social network. So what I'd like to do is talk to you about a patient that I took care of when I was on the palliative care service last month. And you may think of this as kind of an extreme case scenario, but if you think about it, all of us are going to die at some point, and the vast majority of us will be facing decisions as patients in terms of choices at the end of life. So I would say that this kind of situation I'm going to describe is fairly universal, although people tend to approach these kinds of situations usually only once or twice during a lifetime. So this patient was a respected physician, a geriatrician in our community, who developed advanced colon cancer that was rapidly progressive. As a geriatrician, his medical training and expertise put him in close contact with people with serious illness and who were close to death. He had a good cognitive understanding of the situation. He had a large, caring family. His family encouraged him to fight, and what became apparent is that he agreed to at least one procedure that he may not have actually wanted to do in order to satisfy his family's desire that he not give up. His situation now is terrible. He had a massive gastric ulcer that was bleeding despite endoscopic treatment. His blood count was low. He had a biliary tract infection that was marginally controlled with antibiotics. He had a rising white blood cell count. But he was struggling with a decision whether to leave the hospital and relatively soon, with the expectation that he would die at home, or to have one more endoscopic procedure, one more transfusion, one more course of antibiotics, in the hopes that his quality and quantity of life might improve. The oncology team consulted the palliative care team for some help and advice in terms of managing the patient's symptoms as well as helping him to make a decision. When I went in the room, he was surrounded by members of his family, all of whom seemed to want the best for him. And when he was asked what he wanted, the patient only initially asked questions about the next tests, the next consultants, considering first and then becoming distracted from the kind of big picture kind of decisions about what to do next. So here's a question. What's the next thing you're going to say to him and his family? Okay, so what I'd like you to do is, for about 1 minute, turn to a neighbor and just come up with some ideas about things that you would say to this person to help him and his family make a very difficult decision. So just take a minute. Okay, now if this were a small group workshop, I'd ask every person to kind of share their ideas with me, but with the group. But I've done a lot of listening to audio recordings between oncologists and other physicians and patients. And these are the kinds of things that we hear people saying. First, that this is the approach that I'd recommend. It gives you the best chance for success. Given what I know about you, I suggest that you consider such and such. Think about it until you come to a decision and let me know. I really can't tell you what to do. Everybody is different. Let's explore what's most important to you. I really know exactly how you feel. Other patients have found some additional information useful. Okay, so the range of the kinds of responses, and you can think about the ethical, moral, and communicative stance that the physician is taking with each of these statements, but this is what we see in real life. What happened with the situation is that I first assessed the situation, spoke with him and his family, and then excused myself in order to speak with the GI team, the oncology team, the hospice team, and really to try to get a fuller picture of all of the possibilities that might be open to him. And then came back a little bit later, and he said that he knew that this choice was his, but his thinking really wasn't clear. Now, he seemed to be competent to everybody, but he said that he really couldn't see his way through the situation. So I asked him, would you like a recommendation? At which point, and at that point, he seemed quite relieved that to be unburdened from this seeming obligation to make a choice about this situation in which he felt personally overwhelmed. The recommendation I made was that he have no further procedures and go home and enjoy time with his family, which he actually ended up doing. But interestingly, the family were initially disappointed before they were able to actually assimilate the meaning of that decision, that there was this identity of the patient as a fighter and the identity of a patient as someone who was accepting. And it seemed that the patient was in a different place than the family. And I'm going to get back to this whole issue of social influences on decision-making during the major part of the talk this morning. So in complex situations like this, values are competing and contextual. He wanted to live longer and live better. He wanted to have symptom relief, and he wanted to be at home. Decisions are dynamic, iterative, and provisional, so every day he was making choices about what treatments he did or did not want. It was not a single event decision. There was no true sense of closure with any of these decisions. All of them are potentially reversible. His ability to forecast how he would feel about any particular decision was not particularly good. And he tried to delay and defer decisions. The other things to keep in mind is that evidence in these circumstances is not necessarily fact or guideline, that evidence really has to be taken into account of the context. That evidence is a theory, it is not a fact. Okay, it's a potential set of guideposts, but it's really a theory. The facts that we cite as evidence are mostly provisional. Equipoise is rare. People start out with opinions, and sometimes one has to unpack those opinions and question them. Lindblom describes a theory of incrementalism that he calls muddling through, where you not try to see a distal goal, but try to see intermediate goals and make small decisions, because making the big decision is just too either overwhelming or one never has enough information to do so. And I like this definition of phronesis, knowing exactly which rule to break and exactly in what way and how much to break it in order to accommodate to the situation before you. When do you not use antibiotics for an infection? So Ellen Peters and Paul Slovak have written a lot about what they call construction of preferences. Now, part of the definition of patient-centered care is to respect patients' wants, needs, and preferences. But we sometimes make the assumption that preferences are more stable than they actually are. So preferences tend to be unstable in unfamiliar situations, in situations that are defined vaguely. And in palliative care, we hear all the time physicians asking patients, do you want everything done? Well, we live in America and everyone wants everything, so everything sounds kind of good until you realize what you're signing up for. Spending your last days on a ventilator doesn't sound particularly good to most people. If the situation is unfamiliar, if it's affectively charged, if the preference is potentially reversible in response to new information, framing, et cetera. And also in situations where one doesn't have particularly good insight into one's own decision-making processes. And this applies to physicians and other healthcare professionals to the same degree that it does patients, that self-awareness is really important in terms of unpacking unstable preferences. When people are very sick, they tend not to think the same as when they're not sick. And a lot of this is based on a theory called terror management theory, with the idea being is that mortality salience, when death seems close, one tries to reinforce one's sense of self-identity. One tries to be the person that one always has been. And so there's a tendency to try to reconstruct the past and make decisions to try to restore a past that often can't be restored. So that leads to a tendency to oversimplify, hasty decisions, and often people need some kind of bolstering of cognitive function in order to solve problems effectively. Eric Cassell wrote a really interesting article about this, having interviewed a number of patients in the ICU, and found that their cognitive developmental functioning was about that of a 10 or 12-year-old, that just by virtue of being in the ICU, they lost certain capacities for abstract reasoning. They tended to regress in their thinking processes. I think all of you are familiar with kind of the idea that, that decisions involve more than analysis. Okay? It involves more than calculating risks and propensity scores. That there's a discourse of uncertainty, of irreducible uncertainty, that one needs to engage patients with. That non-analytic factors can inform choices, not only disrupt choices. That some situations don't feel real until you're actually in them. You can't anticipate them mentally. Values tend to be contextual and evolving. Options emerge as the situation evolves, as opposed to having a fixed set of known options. And also, that it becomes impossible sometimes to assign quantitative utilities, that sometimes a coaching model seems more appropriate. So for the rest of the time, I'm going to talk about the factors that, social factors in decision making, how patients and their relevant social units actually make decisions together and can possibly be recruited in a way to promote patient autonomy. And in my peregrinations through the literature, I came just in collective decision making, I just tried to figure out like where this comes from. And in fact, there's a literature on decision making in arthropods and in all sorts of species about, and the question is, do you call this decision making? But some of the studies show that in fact there is this phenomenon of groupthink in various phyla and even going down to insects. That is, that groups of, that even when presented with seemingly equal choices, insects make choices in groups. Okay, so I think that the genetic heritage that we have for decision making is very, very ancient. In my reality as a clinician, patients rarely make important decisions alone. Even if they come to the office alone, they go home and talk with friends and family. The majority of visits for serious illness are accompanied, and that clinicians and patients often construct what people have called communities of care, that is, groups of individuals who have some stake in the patient's care. So let me just give you a couple of examples. I asked a patient sometime last month about end-of-life care, and his wife interrupted saying, "We're not ready for that." Okay. A few days earlier, a patient reported that she was feeling fine, but her daughter reported that she had fallen twice in the past 2 days. The patient was hiding information that might actually have resulted in her having been put into a nursing home. I had a patient with advanced AIDS who was struggling with a complex medication regimen, wanting to quit taking medications. Meanwhile, his partner organized the medications into a daily little medication box, which the patient then quite willingly took. And the previous week, a patient was asked by a physician whether he'd like to receive mechanical ventilation. The patient said, of course. But then his wife reminded him that when he saw his father dying on life support, he said that he would never want that when his time came. So these are just anecdotes, things that I see in my daily work. So when people are relatively healthy, if this is our patient, they often will have one connection to the healthcare system. Maybe their primary care physician, who is then networked to other healthcare professionals. When they become acutely ill, perhaps those worlds collide a little bit more, but then they return to where they were before. However, when people are seriously ill, these worlds become muddled. There are multiple connections between patients and multiple healthcare professionals, between families and some of those same healthcare professionals and other healthcare professionals, include communities of care on the internet, et cetera. The relevant social network that seriously and chronically ill patients deal with is often quite large and quite dynamic. They move around. It's never stable. These networks are constantly changing. So for the rest of the talk, I'd just like you to consider a few questions. That is, in what circumstances do people involve others to help make decisions? How do interactions with families, friends, and clinicians affect the way that difficult decisions are made in clinical settings? Who and what influences how and well people construct preferences together? Are two or more minds better than one? What are the benefits and risks of involving others in decisions? Can shared deliberation and what I'll call shared mind be consistent with respect for personal autonomy? And also, what interventions can promote shared deliberation and shared decisions? And here I'd like to introduce the idea of shared mind, which was an idea that I thought was original until I started writing about it and found that there was a neuropsychologist named Zlotov who actually had coined the term back in '08. But he describes these as situations in which new ideas and perspectives emerge through the sharing of thoughts, feelings, perceptions, meanings, and intentions among two or more people. And it's both a state that's achieved and also an interpersonal process. So taking the standpoint of one mind, an individual, decisions are made and negotiated by individuals, but taking a shared mind perspective, decisions emerge as a result of social interactions. That patients engage in what's called distributed or cognitive cognition with clinicians, family, and or potentially information technology. You can kind of offer some degree of personhood to those avatars. Patients discover values and preferences as a result of real or imagined interactions with others. And that autonomy depends upon and emerges through relationships. So this is quite a different view than this more individualistic view that you see on the left side of the slide. And it's not that one is right or one is wrong, but in different contexts, individual versus shared mind seem more relevant. So shared mind is both naturally occurring and intentional. That is, you can be thinking in the same way as someone. You can distribute what Megan calls cognitive work and reduces individual cognitive load. She's done work in the elderly and also with young children, elderly with mild dementia, and you find that elderly couples actually compensate for each other's cognitive deficits and make better decisions together than either one would make individually. And it also reduces anxiety related to cognitive load, and we know that anxiety is the enemy of good decisions. Attunement refers to emotional shared mind, shared emotional processing, feeling on the same wavelength. I mentioned about terror management. The flip side of terror management is the ability to self-regulate in the face of terror. And then the concept of cohesion, when there's sufficient overlap in members' mental models of a situation to permit effective collaboration. So just think about the interactions you have with colleagues, family, patients, friends, whatever, and think about whether those interactions are cohesive or not, whether you're actually sharing a mental model. So the dark side of involving others in care, one of them is what's called pseudosurrogacy. And in listening to audio recordings of oncologists' interactions with advanced cancer patients, very often if there's a third party in the room, that third party will have a conversation with the oncologist as if the patient weren't there. And in fact, make decisions on the patient's behalf as if the patient didn't have capacity. So we call that as speaking as or speaking for the patient in the patient's presence, and often those decisions go unchallenged. Clearly that's something we don't want, is this kind of pseudo-surrogacy situation. Whereas the other extreme of that is speaking with, where everyone really is on the same wavelength and are actually having a dialogue in which everyone's perspective actually further potentiates the possibility of a good decision. So what if everyone seems to agree? It seems that decisional analysis and ethics always seems to involve situations where people disagree, right? But in that situation with our physician, everyone seemed to agree initially that it was good to fight this illness and to do everything possible to extend life. And it was probably a true consensus, but it was a delusional consensus, because they actually were not considering the likelihood that their efforts would fail. So just the fact that there's agreement between clinicians and patients doesn't mean that one doesn't need to examine in greater depth the need for further information as a disruptive force in what seems to be a decision that's been taken already. Okay, so part of one's role as a clinician is to actually question decisions that superficially seem to have been made. So another thing that has been written about by Lamont and Byrne and others is that people who are very sick often attend to others' psychological needs. And in this situation, this patient accepted treatments that nobody really wanted. He maintained a fighting spirit, and he maintained an unrealistic optimism that really didn't allow him to see the situation for what it was. Now, Vicki Entwistle has kind of built on some of the feminist literature about multiple identities. And I find this actually a useful concept because I believe that this particular physician-patient actually had two competing identities, this kind of fighter identity and this acceptor identity. And they were both actually living within the same body, the same person. And so it was important to address both of those, that in fact both of those are part of who he is and that part of his values, even though those values seem to be contradictory. One of my favorite lines from Walt Whitman, the great American poet from the 19th century, is he's going on and on about the world in his poem, A Song of Myself, and then he starts contradicting himself and says, "Oh, I just contradicted myself. I am large, I contain multitudes." And I think that's true for all of us, that we have these contradictions, that values actually are not necessarily singular or concordant. So in the last segment of the talk, I'd like to talk about a few communication strategies that promote shared mind, and just to introduce how we've incorporated this idea into an ongoing study. The first component is information, shared information, but to keep in mind that information is relational, not merely a commodity, that information is always packaged in a messenger. Now, the messenger could be Fox News, it could be your doctor, it could be your mother-in-law, but information is not just neutral, it's not just information. Information's a drug. More of it isn't necessarily better. You want the right dose. That appropriate pacing avoids cognitive overload, and using techniques like ask, tell, ask, or teach back, just asking patients to report back what they understood of what you said, is very enlightening, and people rarely do that in clinical practice. And so what this accomplishes is three things. One is a shared attentional focus. That is, you know you're talking about the same thing. The second is that the preferences will be better informed. And the third is that it will lower anxiety and reactivity so that people can make more considered decisions. And information technology can help do all of that through tailoring and targeting and parsing and affective forecasting, providing other examples, et cetera. And this is where this group has really made some important strides. The shared deliberation piece I like to call muddling through after Lindblom. And we muddled through in several ways. We muddled through the cognitive aspects of the decision, the affective aspects, the social aspects of decision making, and also the organizational aspects of decision making. That is, if we don't have enough time, that creates a limiting factor in terms of how we approach decisions. And then shared decisions. Back in the 70s and 80s, people talked about a negotiated approach to patienthood. To me, that sounds a little like an arms treaty. That you've got two people who kind of try to find a middle ground rather than two people seeking new options to come up with a more creative consensus. To determine the degree to which the decision is provisional versus irreversible, whether goals are clear or evolving, whether we should focus on intermediate or distal outcomes. And then avoiding both premature closure as well as paralysis by analysis. And then checking back to make sure that the decision reflects collective wisdom. And I do this routinely in family meetings in palliative care settings. So how do you enact this? And this is just one approach, and and there are many. But I've been particularly concerned with the lack of preparation that patients with advanced cancer have when they finally reach a point at which treatment harms may equal or exceed the benefits of anti-cancer treatment. And patients are often shocked at these moments. And so there's been an effort to try to engage patients more proactively in decisions so that they're actually better prepared, or proactively so that they're better prepared to make decisions when they have to. And so our approach has been to try to, rather than focus on decisions, focus on relationships, so that actually people have a shared language and a shared platform for dialogue about these important issues. Through coaching patients to ask questions, to voice their perspectives, to clarify their decision role preferences, to be what we call relationally assertive. Interrupt the doctor. Ask the doctor really what's bothering you. And also involving family, because family members are going to be there as well in the same skills, but also promoting collaborative cognition and also promoting patient autonomy and avoiding pseudosurrogacy. At the same time, we offer physicians a 2-session skill building course that's individualized. We use standardized patients and video material that help them develop skills, and they actually practice these skills and get feedback on agenda setting, responding to patients' expressed needs, anticipating and opening doors for unexpressed needs, responding to emotions, and also asking patients whether they would like more information about the future and the choices that they might have. And then ask patients again for their own understanding. Things that we're hoping to see, that we're measuring, more egalitarian communication, stronger relationships, shared understanding of prognosis. It's remarkable how many patients in this study already have checked the little box when asked about the likelihood that they'd be alive 2 years from now. How many have checked 100% likelihood? These are patients with stage 4 cancer. So the degree of misinformation or misperception is really enormous. Stabilization and expression of preferences, greater readiness to participate in decisions, social enhancement of patient autonomy, enactment of preferences, reduced overutilization, so we want fewer patients dying in ICUs, et cetera, quality of life, and also we're following the family caregivers after the patient dies to see if they have less complicated bereavement. You know, you could call this kind of on the borderland between communication research and decision research, But in my experience in these kinds of situations is that if you set the stage, if you provide a platform for shared information and shared deliberation, actually the decision-making sometimes becomes the easiest part. That things have kind of fallen into place in a way that the decisions can be made more effortlessly. I also just want to remind you, there's a model we developed for NCI and communication in cancer settings, that making decisions is inextricably linked to healing relationships, patient self-management, uncertainty, emotions, and information. That is, it's not an activity in a vacuum, that all of these interact to improve healthcare outcomes. And that the triad of informed, activated patients and families, patient-centered and communicative clinicians, and a healthcare system that supports their efforts is really what's needed. You need all three of those in order to improve communication and health outcomes. I just want to close with the same quote that I started with from William James, because I think that I hope that I illustrated through the case and also through some consideration of how groups of people can make effective decisions, that this acquaintance with particulars is particularly relevant and important, and we can't make assumptions that people actually have a shared understanding until we check back with them. That context really is everything. I think we've got a couple minutes for some questions, and again, I just want to thank Victor and Annie and everyone else on the organizing committee for inviting me. It's just been a real pleasure.
So we do have time for one or maybe two questions.
Thank you, Dr. Epstein. That was wonderful. I'm Dan Matlock. I'm a geriatric and palliative care physician at the University of Colorado, and I also work on decision aids. And I wanted to ask you about some feedback that I continually get from people in the palliative care community, and that is that decision aids are worthless because they can't respond to emotion and reflect upon some of these things that you just spoke about. And I pushed back on that, and I wondered, do you think there's any room for incorporating some of these kinds of techniques, like responding to emotion and some of these predictable communication things, in a standardized tool? Like, can you standardize any of this feedback